Simon Smale. I'm a consultant gastroenterologist in York. Welcome to More Than Just Medicine. I thought it would be useful to talk about, following on from a previous video I've done on reflux, to talk about what endoscopists see at endoscopy and the way we can classify reflux and some of its sequelae. Some of which are very benign and not worrying at all, except that they cause troublesome symptoms, and some of which we like to follow up, and I'll perhaps explain why we would like to follow those things up, hopefully without worrying you too much about the implications of that. So when people get reflux of acid into the gullet, a number of things can happen. The first thing that happens is the symptom which we're most likely to get is heartburn. Sometimes people get acid at the back of the throat or a feeling of food coming back up. Of itself, that is a symptom. Now, when people talk about different grades of reflux, people can get what's called non-erosive reflux, which is where we go down with an endoscope. The lining of the gullet, which is where reflux causes the damage, appears to the naked eye with the endoscope as being normal, and that's called non-erosive reflux. In many ways, that doesn't minimise the symptoms at all, and about 50% of people with quite severe reflux symptoms have non-erosive reflux. What that means is that the reflux hasn't caused any obvious or overt mucosal damage, and clearly that's good news. Now, if one gets more acid in the gullet and it actually causes corrosive damage, that leads to a thing called esophagitis, and we can grade esophagitis, which is basically a fancy medical term for inflammation in the gullet, as being grade A, B or C or D, or 1 to 4 depending on which classification you use. But essentially esophagitis can be mild, minor, it can be moderate, or it can be more severe. And then one can get complications of having had esophagitis for a long, long time. One of the more immediate complications is that the motility of the gullet is often disrupted, so the swallowing can sometimes be difficult. But the swallowing can be difficult because of other reasons, particularly if people are developing fibrosis and scarring in the gullet that leads to narrowing, otherwise known as a stricture. Now, strictures we can manage endoscopically by stretching them, provided they're not worrisome or sinister, provided they're benign, what we call peptic strictures. But they are a significant nuisance, it must be said. So that's kind of non-erosive reflux, esophagitis, and then some of the complications of esophagitis, which include strictures. People then often ask about a thing called Barrett's esophagus. Now, the lining of the gullet is very much like skin. It doesn't have a protective layer of mucus that contains bicarbonate to prevent it from being damaged by the acid to which it might or might not be exposed. Unlike the stomach, which the stomach is a fantastic and very complicated organ. It secretes acid, and at the same time it has lining its mucosa, lining its lining, if you like, a thin layer of mucus which protects it from the acid which it secretes. That's not the case in the gullet. So if one gets recurrent exposure of the gullet to acid, when one has had that for a long, long time, one of the responses of the body to that is to try and protect the gullet from the effects of acid by changing the lining of the gullet to be rather more like stomach. In other words, to be mucosa that can secrete a layer of mucus to protect it from the effects of the acid. Now that change is called Barrett's esophagus, and that change of the mucosa from looking like normal esophageal mucosa to more like stomach mucosa is it can be limited to a couple of centimetres, or it can be much more extensive. If you have very limited Barrett's, in other words less than a couple of centimetres, then the risks of that ever becoming a problem are very small, probably less than 1 in 500. And so the current guidance would suggest that we don't need, if that's diagnosed, to follow that up endoscopically. But of course, if you were to develop any symptoms, such as difficulty swallowing, then you should have an early endoscopy. But that applies to whether or not you know you've got Barrett's anyway. If you've got a longer segment of Barrett's, then over decades, there is a small risk that one gets changes within that mucosa that are a little bit like having an equivalent change might be an abnormal cervical smear test for a lady undergoing cervical smears. It's not cancerous, but it's not normal. They're slightly abnormal cells. And so if we detect that through surveillance endoscopy, which we'd undertake every few years, then we would undertake more regular endoscopy. That change, those slightly abnormal cells that aren't cancerous, is called low-grade dysplasia. And then over many years, a small group, and it's not clear exactly how many people with low-grade dysplasia, but probably over a 10-year period, less than 1 in 10, and perhaps even much less than that, perhaps 1 in 20 or 1 in 30, go on to develop a thing called high-grade dysplasia. Now that's a much more worrying finding and is effectively a very early cancer. It's usually very treatable. And what we like to try and do in our surveillance programs when we look down the gullets of people with Barrett's esophagus is look for areas of low-grade dysplasia so that we can make sure that we monitor those very carefully, and subsequently, if they get any evidence of what we call high-grade dysplasia, which is a more worrisome finding, that we can do something more active about it in terms of considering further therapy. So in terms of the kind of presentations of heartburn and reflux, one can get non-erosive changes, and that accounts for over half, probably, certainly about 50% of the people who have symptoms of heartburn and acidity. One can get erosive change, esophagitis, which is a fancy medical term for inflammation in the gullet. One can get complications of that in the form of strictures, and one can get a thing called Barrett's esophagus. And that's something that we like to surveillance if you've got more than 2 or 3 centimetres of Barrett's esophagus. I hope that's of some help in informing you about the changes that we sometimes see with reflux. Take care. Thanks for listening.